Dr. Daniel Amen is a psychiatrist, brain imaging expert, best-selling author, and medical director of the Amen Clinics. He has pioneered the use of brain imaging in clinical psychiatric practice and is a noted expert in the field of the brain and behavior. Dr. Amen's breakthrough research and insights provide hope and more effective treatment for millions of people today.
There are many people who are anxious or depressed or obsessive, prone to anger, they have attentional problems, and they thought their problems were all in their head, purely psychological, if you will. In the research that I've done, what we found is that these and many other problems are brain-based problems, and that when we optimize the brain, their lives become better. We often say, change your brain, change your life, and that's what we've seen. I like the title to this lecture, Better Brains Through Biochemistry. Who had the idea that we could take something and change how the brain worked? How interesting. I mean, for centuries they've been using supplements and natural herbs. 25% of the medications that we have, at least 25%, come from natural substances, from plants, from bark, and so on. But the issue of psychiatric medications really important for mental health professionals to understand. This is not just for physicians to understand. Love this quote from John Milton. The mind is its own place and in itself can make a heaven of hell and a hell of heaven. So I used to live in Barstow. Anybody ever drive through Barstow? And they're like, oh my, 15,000 people in the middle of the Mojave Desert. It's a great place to live. And being in the military for a long time, I just noticed no matter where I was, Washington, D.C., Frankfurt, Germany, Honolulu, Hawaii, Fort Irwin, that there were people who absolutely loved and took advantage of wherever they were. And there are absolutely people who hated where they were and didn't take advantage of it at all. And I think now it has a lot to do with brain function. And so one way to optimize the brain is medication. So we're going to talk about the role of medication in health and healing. We'll look at imaging. We'll look at the positive aspects of taking medication. And we'll look at the negative aspects of taking medicine, because clearly they can be a problem. We'll talk about when to think about referring somebody for medication, and we're going to look at a brain system approach. What medicines seem to be appropriate for what system? So rather than go, here's a list of all the antidepressants, we're not going to do that. We're going to look at, if you have a cingulate gyrus problem, what's likely to be helpful for that? If you have temporal lobe problems, what's likely to be helpful for those things? So in imaging, they've taken studies like SPECT and PET and fMRI and actually shown differences when you scan somebody on or off different medications. And in SPECT, what we look at is blood flow and activity patterns in the brain, and clearly you can see before and after changes. When you make somebody better, their scan gets better. When you make somebody worse, unfortunately, it's all too common, their scan gets worse. And so it's important to realize that psychiatric medications are powerful, and they can have a powerfully positive effect or negative effect. So as we look at these images, it's real easy to understand because we look for three things. Good areas of activity, too little, or too much. Now if you have too little activity, one might think you want to do things to stimulate the brain. So if you have overall decreased activity and they give you Xanax or Klonopin or Ativan, medicines that settle down brain function, you're likely to make people cognitively more impaired. And that is in fact true. and it's a useful way to think of it. If you have overactivity in the brain and you give somebody a stimulant, what you're likely to do is make them more anxious or irritable. So we'll talk about balancing the brain. Looking at a healthy scan, one of our healthiest brains ever, what we see is full, even, symmetrical activity. So the image top left is looking underneath the brain. Bottom right is looking down from the top. Top right is looking from the right side, and bottom left is looking from the left side. And you see full, even, symmetrical activity. You see, well, some people go, well, it's a little bumpy. This woman's 82. This is the healthiest 82-year-old scan ever, probably. I mean, it's just stunning. Now, we also look at the hot spots in the brain. And here, gold, or sometimes you'll see it as blue, is average activity. White are the most active areas of the brain. And pretty much we see it in the back bottom part of the brain, which is the cerebellum. And the reason for that is it's got most of the brain's neurons, or half of the brain's neurons are in that back bottom part of the brain. Okay, so mind, medication, and the soul. Medicine is part of our culture. I mean, medicine makes the front news of the newspaper a lot. Last Friday, I was giving a lecture in Los Angeles. And I write this column every week, as you know, called Brain in the News. And so I open up the Los Angeles Times, or I didn't even open up. On the front page is an article about the FDA. And the FDA is not going to tell parents that mercury is still in vaccinations. And it's like, you have to be kidding me. And the reason that that's news is mercury is neurotoxic. And what the FDA says is there's not enough evidence to worry people. There's not enough evidence, you should take it out. Right? I mean, they make new drugs go through lots of evidence to make sure that they're safe. And to allow something that's we know is not safe in vaccinations is unconscionable. On the same front page is a study about Eli Lilly's new drug that's in research called duloxetine, where they gave it to a woman in a research study and she ended up killing herself. Because medicines can be positive, they can save your life, no question, because they treat depression. They treat psychosis, they can treat violence, but give it to the wrong person and you might make them kill themselves. So medicine is a huge industry and you cannot forget that. There's a bottom line. There's a dollar bottom line for drug companies. And so sometimes they're not always going to do the right thing. And they may let medicines come by that, you know, they're really not sure that's safe. And so you really have to be thoughtful and watchful. Later on in the lecture, I'm going to show you a slide with Neurontin pens. And we'll just talk a little bit about how drug reps work. And it's just important to know that that's a fact of life, that it's big business. And like you need to watch big businesses for some things, like you needed to watch Enron, you sort of have to have your eyes on big drug companies as well. Medicines change brain function, no question. And it can be positive or negative. So what are the positive aspects of psychiatric medicines? Well, the right medicine enhances brain function. That means it can increase access you have to you, can increase access you have to your soul. You know, if you think of dark, evil, awful thoughts as brain dysfunction, settling that down, treating it, actually gives somebody more access to their ability to communicate with God, or maybe even see God in a different way. Medicine can increase your ability to focus, no question, can do that. Can increase your memory. We have this new medicine, Namenda, that is very exciting. It's actually been approved for moderate to severe Alzheimer's disease. It can improve empathy, especially if you get access to the front parts of your brain. And it can improve your relationships, even your ability to love. So some examples. I'm going to tell you about Samuel and Red. Sari was a woman who had terrible PMS, left her husband during the 10 days before the onset of her period on 3 separate occasions. Last occasion, attacked him with a knife. Scanned her in that bad time of the cycle. My goodness, brain was just on fire. And scanned her 11 days later at the good time of her cycle, her brain was normal. So what we wanted to do was balance her brain even during the bad times of her cycle. And we know certain medications help to do that. If we look at Red's brain, this is a man who came to see me after a serious suicide attempt. Nasty, mean, irritable. Didn't like him very much. Nothing was good enough for him. And the reason he had a suicide attempt is his wife left him because he was physically and emotionally abusive to her. And when we scanned him, we saw this overall dramatic hyperactivity in his brain. For somebody who's in their late 40s to have a brain this hot is very unusual. And so we put him on Depakote. Depakote's an anti-seizure medicine to sort of calm things down. And then we put him on an anti-obsessive antidepressant, calm down his cingulate gyrus. And within 3 months, he's like one of the sweetest people that you would ever meet, which caused me to ask this question: is who is he really? What's his soul like? What kind, who is he? And I would argue he's really who he is when his brain works right. The brain on the right is who he is 3 years later after his brain is tuned. And this boy, oh my goodness, this is the kind of kid that is a nightmare for therapists. He comes into your office, he came into my office, his big Oakland Raiders jacket on, his hat on, you could hardly see his eyes, and his first comment to me, well, I can't say it, but it was like, F you, I'll never talk to you, why are you wasting my parents' money? I mean, just hostile as can be. And, I looked at him and smiled and said, well, it's nice to know you as well. And I just couldn't make any progress with him. And then finally I had to threaten him that if he didn't get a scan, because he wouldn't cooperate with anything, that I was going to recommend basically they send him to a residential treatment facility because he wasn't going to school, he was starting fights at home, he had thoughts of making bombs. I mean, it was not good at all. And so he got the scan after much sort of encouragement and even bribing him. And what we saw, the image on the left is looking down from the top. You see those 3 racing stripes? Well, those are in the front part of his brain, in his frontal lobes. And they're horrible. And as soon as I saw the scan, I then developed a much more empathy for him. And he saw the scan, and it's like, can you help me? So big difference in the attitude. And this is where I put him on Risperdal, one of the relatively new, atypical antipsychotic medicines that we know sort of calm down activity in the frontal lobes, but don't crash it. And 3 weeks later, I saw him back. Actually, a week later, his mother was in my waiting room, and she didn't have an appointment. And I saw her, and I smiled at her, and I'm thinking she doesn't have an appointment. And she came up and kissed me, and she was cute. So I liked that. I said, what's that for? She said, you can't believe it. He's so much better. And so a couple of weeks later, a month later, I scanned him, and I saw it was already beginning to sort of settle down. And 6 months later, still was better. Scanned him again. It had really done the work it needed to do. Withholding medicine from this kid is like withholding glasses from somebody who can't see. It's like withholding insulin from a diabetic. It's not fair. Okay? But medicine is not simple, right? It's a double-edged sword. The wrong medicine can kill somebody. The side effects can interfere with people's personality. We had that discussion today. Take too much Ritalin or too much Adderall, and it flattens you. Now, initially, parents of hyperactive kids like that because it sort of gives them a break. But over time, they really don't like that because you don't hear your child laugh. You don't see that sparkle. They're flat. You can have sexual side effects, especially from the serotonin medicines, the SSRIs like Paxil or Zoloft or Prozac or Celexa or Lexapro. And that can cause distance in relationships. They also can decrease motivation. They decrease frontal lobes too much. I mean, we saw that boy whose frontal lobes were on fire. Well, if I decrease them too much, well, now I won't care. And that can be a bad thing. And I think with the availability of psychiatric medicines, I mean, they're everywhere. They're on Super Bowl commercials. They may be causing us to be too reliant on medication and not reliant enough on helping people build skills. Because as therapists, that's really what you want to be doing, is helping people build skills so they ultimately need less medicine. Now, maybe they don't need no medicine, but they may need less medicine. So just a couple of examples of how medicine can make things worse. I have a 7-year-old patient by the name of Joshua. His mother gave him St. John's wort after she saw it on a talk show. St. John's wort is an herb that they use for anxiety and depression and obsessiveness. He then started to have dreams of decomposing bodies, and he tried to kill his mother. And later we found out he was bipolar. Kip Kinkle, some of you will remember that story, had been prescribed Prozac. Also prescribed Ritalin. The Columbine shooter, Eric Harris, was taking Luvox. And clearly, in my experience with serotonin medications for people who are bipolar or who have left temporal lobe problems, you can flip them and make them extraordinarily aggressive. Now, does that mean these medicines are bad? No. They're bad for the wrong person. I have a business executive. He was running a big radio company. And on Prozac, his anxiety went away. So now he didn't show up to board meetings. And he wasn't doing his taxes. And he went, I don't think this is really a good thing. I'm feeling good. But I'm not getting stuff done, so I don't think I will be feeling good in the long run. This is Kip Kinkle's brain. So if you look at a healthy brain versus Kinkle's brain, you can really see it's abnormal. Now, it needs medicine. It needs treatment. The one they chose was just wrong. Will medicine make me someone different? Will it make me be a cat drinking out of the toilet? It's not the goal. The goal is to help you be who you really are when your brain works right. And not if you need the medication. It's the right medicine for you. But clearly the wrong medicine will make you do goofy things. Okay. So when to think about psychiatric medicines? Certain illnesses, like schizophrenia or bipolar disorder, your first thought after a good evaluation, make sure it's not because they're hyperthyroid. Your first thought should be get them on medication. Why? Because they're progressive. And, schizophrenia usually has a progressive downhill course. And if you treat it effectively early, you can help them be without psychotic symptoms. And psychotic symptoms will ruin somebody's life, ruins marriages, ruins your ability to work, it ruins the interactions you have with your children. Bipolar disorder, a lot of people really like the uptime, but it ruins them, right? They spend money they don't have, they have affairs, they become hypersexual, hyper-religious, really without forethought. And then, beyond those two, you really have to look at the severity of the illness. So for major depression, well, sometimes major depression will respond to cognitive therapy. Sometimes it will respond to interpersonal psychotherapy. Sometimes it will respond to EMDR. So you don't necessarily have to first thing think about medicine, but it sort of depends on the severity of it. If it's major depression, severe, probably medicine's the first thing, because odds are they have suicidal thoughts or they're not getting out of bed. But say it's chronic and low grade and they're still doing their life, well, maybe you give them a course of cognitive behavioral therapy or interpersonal psychotherapy and you watch and you see how it does. Now, if therapy's been ineffective or despite treatment it's interfering with their ability to function, you bet you go after it with medication. Now, I prescribe medicine not based on DSM-4 diagnosis. It's just, you know, if you take major depression, there's a whole bunch of different kinds. Or even if you take bipolar disorder, there's a bunch of different kinds, or attention deficit disorder. And so if you're prescribing based on diagnoses, you'll make some people better and a lot of people worse. Study from UC San Francisco said that if you come in with major depression and we put you on an antidepressant, we have a 30% chance of getting it right the first time. That's because they're treating DSM-4 categories, which are arbitrary. You know, with DSM-4, people came up with clusters of symptoms. And then they got together in a room, in a hotel somewhere, and they voted on, okay, this makes major depression, this makes it ADD, and so on. Better to take a brain system approach. So we'll do that. We'll look at the systems that we've looked at before. Think of the prefrontal cortex. It's your supervisor. It watches you. It helps you with things like forethought and judgment, impulse control, organization, planning, empathy, insight, learning from the mistakes that you make. Okay? So we think of it as the executive part of the brain. When it works too low, it's like the executive's gone. It's like there's no boss at work. When it works too hard, it's like the executive is micromanaging you. So when it is low in activity, people have ADD-like symptoms, short attention span, impulse control problems, procrastination, disorganization, poor judgment, lack of empathy and insight. Okay? So when it's low, you want to do what you can to stimulate it. Now, some of the problems we see when it's low are things like ADD or ADHD. You can develop bad habits because you have little forethought. One of my young workers at the office a couple of weeks ago was outside smoking, and it just made me furious because he knows better. And so we did lots of, we call it frontal lobe interventions, on educating him on why this is really stupid. So what we also find is schizophrenia has often low activity in the prefrontal cortex. And the old medicines for schizophrenia, the old antipsychotic medicines, would calm down dopamine availability in the brain. It's the neurotransmitter that in the limbic part of the brain, when it is really cooking, people have psychotic symptoms. And so what happens with these medicines is they would settle all that down and they'd be less psychotic. The problem is it calms down dopamine everywhere, including in your prefrontal cortex, so now you can't concentrate. And the new medicines, especially a new one called Abilify, modulates dopamine, which means it lowers it in the limbic part of the brain and raises it in the prefrontal cortex. So some of the new medicines are better. Brain trauma, you bet, can damage activity in the frontal lobes. Sometimes stimulants really help get them function back. Antisocial personality disorder, 11% less cells in the prefrontal cortex. There's a study by Rachel Klein at New York University where she took conduct disordered kids who did not have ADD. Conduct disordered kids, no ADD, put them on stimulant medications like Ritalin. And what she found is they got better. Is they had much better behavior, more thoughtful behavior. So, we should be giving things like Ritalin to people with prefrontal cortex problems, not when they meet this certain cluster of symptoms. Frontal temporal lobe dementia. As we age, people who lose their minds, their memories, often have their frontal lobes deteriorate. Activating them can be very helpful. So, now many of these conditions are due to either low dopamine or norepinephrine levels. Epinephrine is another stimulating neurotransmitter. If you have low serotonin, what you then have is a brain that's fired up. Your frontal lobes work too hard, and that's where you can get into obsessive compulsive spectrum disorders, at which point if your frontal lobes are overactive, we think of serotonin medicines to calm them down. So I think of prefrontal cortex medications as stimulants that increase dopamine or norepinephrine. Adderall. The tablet is a picture, actually, of Adderall. Dexedrine, Ritalin, Concerta. It's a new medicine from Eli Lilly called Strattera. Provigil. Provigil was actually a medicine used for narcolepsy. But they found it helped with energy and it helped with motivation. So they started to use it in the military when people had to stay up for a couple of days at a time as something that might be helpful for pilots and so on. Now, is there evidence that stimulants balance brain function? Well, there's a study from Korea, from Kim in 2001 on 32 patients. He showed increased activity in the prefrontal cortex with stimulants in people who had ADD. Another study in 2002 found that MPH, that's methylphenidate or Ritalin, modulated frontal and prefrontal cortex activity. Rode in 2003. And this is where it's going to go. In part, as we talk about imaging, and imaging is part of the future, genetic testings and typing people based on their genetic makeup, genotypes, found that certain genotypes respond differently to medications and have different imaging patterns. And so as we mix imaging with gene testing, we're going to find you're going to be much more likely to respond to this, and this is going to be a nightmare for you, so we don't want to use it. We look at how scans can change. We see before and after stimulant medication. I mean, a dramatic difference in a girl that had ADD. This is a person who had ADD and a condition called alexithymia, which is you don't have access to your own feelings. So how do you feel? Well, I don't know. Or how do you feel? Fine. And what fine means is I have no clue. And please don't ask me that anymore. So it's very important when you're interviewing people and you go, how's it? If you can't get feeling words out of them or any color or detail to the feeling words, that's important. This guy had a football injury, and he came to us not because he had the problem. His wife came because she had a temper problem. And we finally figured out why she had a temper problem. She could never get her husband to react to her. And so she kept escalating her behavior. So if you look at it before medicine and then look at it after medicine, very nice job of sort of filling things in. So what are we doing? We're not making him different. We're helping him be who he is when his brain works right. So what about people who have problems with the cingulate gyrus? We've talked about the cingulate gyrus as the brain's gear shifter. It allows you to go from thought to thought, move from idea to idea, be flexible, go with the flow, cooperate, get outside of yourself and into other people. And so here we're looking at a brain from the left side, and the arrow is pointing to the anterior front part of the cingulate gyrus. And when there is too low the neurotransmitter serotonin, the cingulate gyrus fires up. And the basic underlying mechanism of many disorders is they can't shift their attention. They end up locked onto things, stuck on things, same thought in their head over and over. You see that in eating disorders. You see it in anxiety disorders. You see it in post-traumatic stress disorder. You see it in obsessive compulsive disorder. You see it in depression. You see it in panic attacks. But isn't it interesting that even though Prozac and medicines like it are indicated for depression, is that they really have a very wide range of use. And if you were just giving it to people who met the certain DSM-4 diagnosis, you would really not be helping as many people as you could be helping. So some of the conditions associated with too much activity in the cingulate gyrus: anxiety, generalized anxiety disorder. You got to worry and you can't let go of it. Panic disorder, over-anxious disorder in children, or social phobias. You know, I can't go to that party because they're going to look at me. And somebody's going to try to talk to me, and I'm not going to have the right answer, and they're going to think I'm stupid, and so I just can't go. And it's not like they hear this thought once, right? It's like they hear this thought repetitively, and it's the repetitive nature of the thought that does them in. Post-traumatic stress disorder, you get traumatized, and then what happens is you can't let go. It comes and stays. It actually burns a path in your neuronal system. OCD spectrum disorder, so obsessive compulsive disorder, washing your hands, checking locks, or getting these horrible thoughts you can't let go of, but also things like trichotillomania, hair pulling. What is that? Well, you get stuck. I mean, we've seen some kids that they look like they're cancer survivors. Even though they don't have cancer, they pulled out all their hair. I don't have enough, so I can't get into that. Tourette syndrome is called a OCD spectrum disorder, as is pathological gambling. Eating disorders, anorexia, hot frontal lobes, bulimia, hot cingulate, low activity on the underside of the frontal lobe. So anorexia is more an OCD disorder. Bulimia is what we call an impulsive compulsive disorder. Brand new study showed that bulimics had 3 times the level of attention deficit disorder as anorexic. So now what we begin to see are systems interacting. And so you have to understand that all of these systems that we'll talk about, they interact with each other. So if you have high activity in the cingulate gyrus, and low activity in the underside of the prefrontal cortex, you have what we call an impulsive compulsive disorder. Well, what if you have high activity in the cingulate gyrus and high activity in the underside of the prefrontal cortex? You have terrible OCD, right? There's no impulsivity about it. What if you have low activity in the cingulate gyrus? You have no motivation. And low activity in the underside of the prefrontal cortex, you have no impulse control and no motivation. So you just don't care. Right? And so you target the medicine to the system. So the medicines that we use to calm down the cingulate gyrus are serotonin medicine. And we have 6. Paxil, Zoloft, Prozac, Luvox, Celexa, and Lexapro. So Prozac and her 5 sisters. Been around now 16 years. Prozac came out in 1987. For many years it was considered a second-line drug. When it first came out, we had, the first-line drugs, which were tricyclic antidepressants. And what we realized is the tricyclic antidepressants, if you give them to somebody who's suicidal and they hoard them, and they take like a whole bunch of them, it can kill them. And you can overdose on Prozac and it won't kill you. But if they give you Prozac and it's the wrong thing for you, you'll kill somebody else. But you still have to be cautious with these medicines. One of my favorite medicines is Effexor, because Effexor raises serotonin and norepinephrine. So if you have a hot cingulate and low activity in the prefrontal cortex, Effexor is the right medicine for you. For severe cases, like that boy that had 3 racing stripes going down his frontal lobes, we used the new novel antipsychotics like Risperdal or Zyprexa or Abilify or Geodon. For the more mild cases, we'll use supplements like St. John's wort. This is the place where St. John's wort shines, where it really does its best job. Is there evidence, in the scientific literature about these medicines in the brain? Well, there's a study by Stein in 2002 that Celexa lowers frontal lobe activity, exactly what we see in the scans. There's another study in 2000. Celexa lowers frontal lobe activity. In this one, people who didn't respond had increased temporal lobe activity. And in our experience, if you have abnormal temporal lobe activity, treat it first, or the other medicines will irritate it. A very important study for me in 1991, right as I was starting my brain imaging work, Hoa and Sarek published a study in the American Journal of Psychiatry, said that treatment with Prozac and Zoloft and anafranil significantly reduced the patient's hyperactive frontal lobe. And it just made perfect sense to us. Studies from UCLA is that these medicines also decrease basal ganglia activity. So there's really a loop between your frontal lobes, your cingulate gyrus, and your basal ganglia. So this is a patient of mine who had very severe depression with suicidal thoughts and irritability and anxiety. And you see at the top her cingulate gyrus is overactive. See those large structures in the middle, it's her basal ganglia, so she's really anxious. And if you look at the study before medicine and then look at the study after medicine, well, you start to get pretty excited. And one, you realize that she's not acting badly because she wants to be acting badly. And that the medicine really helps to balance brain function. And this was with Prozac and psychotherapy. I mean, the best treatment is usually a combination if they need medicine. Okay? Medicine-only treatment is bad treatment. Because people need skills. So that when this comes and bites her again, she has better interpersonal skills. She has better cognitive skills. She can kill the ants that just come and invade her when her mood comes. She has some armor to help and protect her. It's another girl, similar situation, very depressed. Now this is before and after Prozac. Dramatically better. But what she said is, I'm better, but I can't do school. At least before I was getting my work done. Now I'm not getting my work done. And if you look at the undersurface of her brain, this is exactly what we see in scans. Is that the SSRIs, they take down your frontal lobes. Now if you're starting with really hot frontal lobes, taking them down is important. You just don't want to take them down this much. And then you have a choice. You can either back off the medicine and see, maybe you should just do better on a little bit, or you can add a stimulant to try and balance it. And what you're always thinking about as a psychopharmacologist is how can I better balance this person's brain? And the cool thing is if you have pictures, in some ways you get to cheat because you get to look at what you're doing rather than guess, right? Which is what our colleagues do. They are educated guessers. The next system to really pay attention to is the basal ganglia. Integrate feeling and movement. This is why you jump when you get excited. I mean, if you saw the NCAA tournament, they win and everybody's jumping around because they're getting all that energy through their basal ganglia. Controls your body's idle. So when it's up, you're anxious. When it's down, you're unmotivated. Modulates anxiety and controls smooth motor movement. And what we find in the basal ganglia is that when it is too active, people are anxious. They have panic attacks. They tend to be conflict avoidant. Why? Because they don't want to go anywhere near anything that's going to make them anxious. They may have excessive motivation, can't stop working. If it's decreased, they have ADD-like symptoms. Maybe decreased motivation. As we see in people who have Parkinson's disease. As Parkinson's disease erodes dopamine production in the basal ganglia, they don't move, they don't talk. They're not as interested. Many of them look very depressed. And so the medicines we use to calm that down are medicines that enhance a neurotransmitter called GABA. GABA is 25% of the neurotransmission in your brain, and it's what we call an inhibitory neurotransmitter. And we think that benzodiazepines work on GABA. Benzos like Xanax, or Ativan, or Klonopin, or Transine, Valium, Librium. We got a lot of them. The problem with benzos is they're addictive. And it sort of takes more and more to get the same response for many people. And over time, their brains don't look very nice. Their brains really begin to take on a toxic look. Buspar, which really never did great because it took 2 or 3 weeks to work. And if you compare that to something that works like immediately, this is America. I want it fixed today. So Buspar never really caught on. What I use in my practice is I use anti-seizure medicine. I use things like Neurontin for anxiety. Just put somebody on it today. Neurontin is really good for anxiety, irritability, and pain. And we think it calms down activity in the basal ganglia when it works too hard. I mean, it calms down activity everywhere that works too hard. So the problem with it, if you use too much, you calm down things too much. Now people complain of memory problems. I'm not anxious, but what was your name, doctor? Sometimes we find antidepressants work for anxiety. Wow, that's kind of interesting. Imipramine, desipramine, Effexor. Or MAO inhibitors. Now, you probably don't hear much about MAO inhibitors anymore because many people think they're really dangerous and you have to avoid certain foods. Well, the truth is, only 1 in 90 people you put on it have to avoid those foods. But if that one person gets it while he's taking that medicine, he can have a stroke. I mean, it really can just send their blood pressure through the roof. These are often great anti-anxiety medicines, especially one called Nardil. I have had, probably a dozen patients through the years. Their anxiety was so high they were going to kill themselves. And nothing I did worked until I put them on Nardil. I mean, and then it was just stunning. So even though we don't use them very often, when we need them, sometimes they are just amazing medications. Benzos, as we talked about, lower overall brain function. So it often gives a toxic appearance to the scan over time. This is one of my patients who had been using, prescribed by her doctor, Xanax. And, after I saw that, I stopped really prescribing them. I used to prescribe a lot of them because where I trained at Walter Reed in the early 1980s, they were giving Xanax to everybody. I mean, sometimes really high doses. You're depressed? Here, take 10 milligrams of Xanax. And they were not depressed anymore. They were actually not anything anymore. Flat, but wanting their Xanax. Okay. And then if we look at the temporal lobes, language, memory, mood stability, listening, reading social cues, rhythm, music, spiritual experience. Wow. So when there are problems there, you have problems in those areas, like emotional instability, memory problems, feelings of panic, aggression, headaches, learning problems. So would it be a good idea to put people who had temporal lobe problems on anti-seizure medicine? Now, what in God's name why would you do that? Well, when I first started doing scans in 1991 and I saw all these temporal lobe abnormalities in my patients, I went to the literature on imaging and I said, who's got temporal lobe problems? Patients who have seizure disorders, right? When you're having a seizure, your temporal lobes are hot. When you're not having a seizure, your temporal lobes are cold. And so I started putting them on anticonvulsants. Now, it wasn't all that radical because even in my training program, we were putting bipolar patients in the early 80s on Tegretol or on Depakote. Solid, good, effective anticonvulsants. And now it's really the standard of care that if you have a bipolar patient, that we start with anticonvulsants. And so it was just putting the anatomy, the physiology, to what I was doing with medication. And my first patient I tried this on was 12, Christopher. Cute, but trouble. Oh my goodness. At the age of 6, he was diagnosed with ADHD, put on Ritalin. He started having hallucinations on Ritalin. So they took him off. At the age of 9, he attacked a kid, and they put him in a psychiatric hospital in Alaska. His father was in the Air Force. And they put him on dizipramine. They thought, well, maybe he's depressed. Got worse on dizipramine. Took him off. And when I saw him, he was 12 years old. He had been in my community for the last couple of years. There's a big Air Force base there. And terrible behavior, terrible learning problems, very aggressive. And he'd been seeing a psychoanalyst in the Napa Valley. And one day, he takes a pencil to another kid's neck at school and attacked him and hurt him. And now, Chris ends up in the psychiatric hospital where I'm on call as the child psychiatrist. And his doctor's last comment to Chris's mother was that if only she would get into therapy and deal with her own childhood issues, then this child's problems would go away. Do you know what that's called? It's called psychiatric abuse. And it still goes on, right? Because if you never look at their brain, how would you know? See, it's easy to come up with the idea it's your fault if you don't know. It comes up all the time with people who are married to people with ADD. People who are married to people with ADD end up to be over-controlling. Because if they're not over-controlling, nothing gets done. And then they go to marital therapy, and the therapist goes, you're over-controlling. It's your fault. And internally they know, if I don't do it, nobody will do it, and then he'll fail. We won't pay our taxes. You know, all the clothes will remain at the dry cleaners, and we'll never eat. So he blamed her, and Chris is on my service. And I remember the day he was admitted, because what I used to do with the kids I was seeing is I'd take them all outside as a group and we'd play football. Not tackle football, touch football. And Chris was on my team, and every single play he cheated. You know, it's like after the play, somebody put the ball down, and he would take the ball, bring it back 3 steps, put it down, and look at me with that look like, well, are you going to yell at me now? I mean, just conflict-driven. And in my mind, I went, you know, I'm not going to yell at you. I'm going to scan your little brain and find out why you act like this. And so when we scanned him, this is the 3rd scan I ordered. I mean, it's in the 1st week, that very important week for me personally. He had a deficit in his left temporal lobe. And the left temporal lobe subsequently has become very important because that's where the bad guys' temporal lobes are. That's where Kip Kinkle had his temporal lobe problem. My nephew, who attacked somebody for no reason, that's where his temporal lobe problem was. And that's when I went to the literature. I go, temporal lobe? They never taught us about this in school. And it's associated with seizures. And he had a normal EEG, and the neurologist we work with said he didn't think he had seizures. But what the heck, I put him on Tegretol. He'd already failed a stimulant, failed an antidepressant, put him on Tegretol. And now he's like the sweetest little boy that you would ever meet. And he stayed like that. In fact, when I discharged him a month later, we played football again because it was a weekend and I'm on call. And he's like cooperative when we're playing football. Now, what's more effective, right? To work in a team and be cooperative, or to be upsetting everybody in the environment? See, I would argue being cooperative is more effective social behavior. 5 years later, I'm still seeing him. And the principal of his school asked me to go give a lecture at his high school. Now he's a senior in high school. I walk on campus, and I see him. And he gets a big smile, comes up and gives me a hug, introduces me to 5 of his friends. I have to tell you, that was a very important moment for me. Because what do you think would have happened to Chris if we wouldn't have figured out his brain? He'd be in juvenile hall. He'd be in the California Youth Authority. Or he'd, be headed toward adult prison. And isn't that a little bit unfair? That he has a temporal lobe problem, and because doctors don't look and are not sort of smart enough to figure it out, that we condemn his life, and we just don't hurt Chris. I mean, let's be honest. Who else gets hurt in the process? The people he hurts, and his mother, who people blamed as a bad mother, who takes to her grave the pain and suffering of having somebody who has a mental illness that nobody figured out. So, some of the conditions affecting the temporal lobes: learning disabilities, dementias, epilepsy, people with aggressive or suicidal behavior we don't really know how to categorize, brain trauma, and people who have abnormal or probably low levels of GABA, the neurotransmitter that inhibits overfiring. So we use anticonvulsants. So if the problem is irritability, mood instability, temper problems, use anticonvulsants. My favorite one is Neurontin, if they're not bipolar. If they're bipolar, stay away from Neurontin because it doesn't work. But it works for anxiety, and it works for irritability, and it works for some pain syndromes. And isn't it interesting? Temporal lobe abnormalities are often associated with abdominal pain. It's called abdominal epilepsy. There's one called Topamax that we use for those issues, especially if you're overweight, because 15% of people on Topamax lose weight. We use Depakote or Tegretol. Another word for Tegretol is Carbatrol. It's just a different brand. Very effective for people who have seizures and cyclic mood disorders. Lamictal, which is effective if you have depression and irritability and a cyclic mood disorder. Gabatril, which we're now using for anxiety disorders and sleep disorders. And the old standby, Dilantin. It's an old medicine. But there's a wonderful book that you should read at some point. It's by Jack Dreyfus. I don't know if you follow mutual funds. He's actually the founder of the famous Dreyfus Mutual Fund. He wrote a book called A Wonderful Medicine Has Been Overlooked. And it's all about Dilantin. And in the book, he lists 255 scientific abstracts on the use of anticonvulsants in psychiatry. And what happened is he went to psychoanalysis, didn't help him. He was on antidepressants and anti-anxiety medicines, they didn't help him. And he put him on just a little bit of Dilantin, and he felt normal. He didn't feel depressed anymore, he didn't feel anxious anymore, he felt like himself. Now, the reason that you see Neurontin pens on this slide is because many doctors get their information on medications from drug reps. And they come out with this really flashy, Madison Avenue, really cool advertisements for these. And they give doctors things that will remind them of their product on a regular basis. And you just have to know, where does your doctor learn about medications? Well, often from CME presentations put on by the drug company. Right? I mean, for a couple of years I was a speaker for Adderall. I mean, I liked it. I liked teaching, liked talking about ADD. But you see that subtle pressure. And not so subtle because drug companies also bring the doctor's offices lunch and cookies. And what they're really doing is they're getting in good with the office manager. Because if you can get in good with the office manager, she'll put you on the doctor's schedule. And they give you samples. So what medicine are you going to use with somebody? Well, something you have samples with that you can start the patient on right then and there in our immediate need culture. The problem with it is those medicines tend to be a lot more expensive and maybe no more effective than some of the older medicines that we have. So you just have to know that's a part of the culture. So a patient of mine who is a domestic violence perpetrator, and this is before and after valproic acid or Depakote. What about the literature? Well, in 1998 there was a study that demonstrated that Depakote, sodium valproate, Depakote's the same thing, influences the cerebral blood flow in children by decreasing the flow significantly. So if you have what we call the ring of fire, diffuse overall increased activity, helps to settle it down. Other studies as well, a study in 1996 showed that valproic acid, VPA, or CBZ, which is carbamazepine or Tegretol, and phenytoin or Dilantin decreased blood flow, but less than some of the other ones. And we know phenobarbital and Valium, I mean, they slam blood flow down. So they're more likely to have cognitive problems associated with them. And one interesting thing with anticonvulsants, if you have a patient that's on an anticonvulsant and they start to complain of memory problems that they didn't have before they were on the anticonvulsants, their dose is too high or they've been on it for too long. Okay, let's talk about another form of a temporal lobe medicine that help memory. Because sometimes, if you have temporal lobe problems, they're not angry. They don't have dark, evil, awful thoughts. Their mood's not really unstable. They just can't remember anything. And we use memory enhancers. And from a medication standpoint, we use something called acetylcholine esterase inhibitors, which means we block the enzyme that breaks down acetylcholine, leaving more acetylcholine in the synapses. And what we find is it really helps people's memory. I had one patient once who said, after she took Aricept, that it was like going from 8 megabytes of RAM to 128 megabytes of RAM in her head. She could hold things better. And so if you see ACE with the little I, that stands for acetylcholine esterase, the enzyme that breaks it down, inhibitors. It inhibits the breakdown. Brand new medicine called Namenda. And it's just been approved for people who have moderate to severe Alzheimer's disease, and it modulates glutamate. Now, glutamate is the most common neurotransmitter in the brain. It's responsible for like 70% of neurotransmission. And when you have enough, you can learn. You can remember. You're awake. When you have too much, it's toxic for cells. And what Namenda does is it helps to balance it. So if there's too much, because you're under too much stress, what Namenda helps is keep sort of a lid on it so it doesn't boil over. Lots of excitement about this medication, especially when it comes to Alzheimer's disease, but also in learning. Now, when we look at dementia, there are a number of studies that say the memory medicines, like donazepam or Aricept, actually boost activity in the front part of the brain. So, you know, these are things that are, again, targeting and changing brain function. This is a case that's very special. It's a guy that had encephalitis when he was 3, completely wiped out, killed his cerebellum. So if you look at the images, you see he's got no cerebellum in the back bottom part of his brain. But he also had social skills problems, concentration problems, and his family really didn't want to talk to him. And the image on the left is before treatment. The image on the right is with treatment with Namenda. And what we saw is his right temporal lobe increased in activity. So he's going to better read social situations. So medicine for social klutzes. Sort of an interesting idea. And if you look at the top part of his brain, you see the holes in his prefrontal cortex, they're better on this medication. And the exciting news is as it stimulated the brain, it didn't overstimulate it. This is the same person, image on the left. At the top you see that round ball, his cingulate gyrus is working too hard. The image on the right, on the Menda, calmed down his cingulate gyrus. So it balanced, and that's really what we're looking for our new medicines. Not that they rev you up too much or they take things down too much. It's that they help balance. We look at depression. We look at the limbic system, which integrates and gates sensory information, is involved in setting your emotional tone, bonding, storing highly charged emotional memories, smell, and libido. And we know when the limbic part of the brain is fired up, people are sad, negative, moody. They have lots of ants, low motivation, social isolation. They lose their libido. And we have things like depression, cyclic mood changes, pain, sensory overload. And here there's usually too low in one of the main mood neurotransmitters, dopamine, norepinephrine, or serotonin. And what we find, the antidepressants do actually a pretty nice job. Now, if you have a hot cingulate, it predicts a positive response to an SSRI. If the issues are not cingulate, they don't worry. They're not inflexible. Things don't go their way, they're fine with it. Don't use an SSRI. Because if their frontal lobes don't start out as hot, and you put them on an SSRI, which we already talked about, decreases frontal lobe activity, you're going to make them stupid. Okay? So if it starts with a hot cingulate, start with an SSRI. There's no cingulate stuff. Start with the stimulating antidepressants like Wellbutrin or Dazipramine. So if we look at depression, it starts out with a hot cingulate. Now if we look at bipolar disorder, everything is hot, and so doesn't it sort of make sense? You want to increase GABA and settle everything down? That's why we use anticonvulsants with that condition. And just a little bit about antipsychotics. Studies have found that with antipsychotics actually improves activity in the frontal lobes with the newer antipsychotics. And it balances the loop between the basal ganglia and the prefrontal cortex. Study in 2002 from Nagan showed that risperidol decreased the hyperfrontality. It's the same thing I showed you in that early case of that kid that was suffering and difficult. And even in 6 elderly patients in a study in 1996, calmed down excessive activity in the frontal lobes. And one of my favorite scans of all time, patient had paranoid schizophrenia, wouldn't take his medication because he had old medicine that made him sick. You look at before and after, and the one-liner that I gave to him is, which brain do you want? Right? Well, I want the healthy brain. Because if you look at the brain on the left versus the brain on the right, I mean, what you're really doing is giving him his life back, right? So what you say to people who say, oh no, psychiatric medicine is bad, it's like it saves people's lives when used appropriately. And that's got to be what you say, when used appropriately. So in summary, medicine's clearly, it's a double-edged sword. Medicine can tune and balance the brain. Medicine can hurt the brain. Specialists generally do a better job. It's a huge study on ADD, looking at child psychiatrists prescribing medication versus family practice and pediatricians prescribing the medicine. If you go to a child psychiatrist, you are likely to get better significantly faster than if you go to a pediatrician or a family practice doctor. It was very clear from what people think of as the largest, best designed study on ADD in the world. And I think you need to take a brain system approach. So the question is, you have a friend who's been diagnosed with bipolar disorder, and he's been put on venlafaxine or Effexor, and that made him a zombie. And then he was put on Depakote, and that made him too happy. Valproic acid and Depakote are very similar. Typically, for bipolar disorder, if you put him on Effexor without first putting them on something like Depakote, you can send them through the roof. You can actually flip them into a manic episode. We think that's a dangerous thing to do. So what you usually do is you pre-treat them and you get something that works with Depakote, Tegretol, lithium, Lamictal, and in that way hope you can settle them down, and then what an antidepressant will do is prevent the real lows from happening. But not everybody's the same. Not everybody who has bipolar disorder is going to respond to Depakote. So you often have to go between medicines to find out what's the right fit for their brain. And one of the things we hope to do as we go along is look at what brain pattern responds to lithium, which one responds to Risperdal, which one responds to Depakote, so on. When people say, oh, doesn't that mean that everyone needs to be on medicine? You say, absolutely not. I mean, one of the things that I've learned is that really great psychotherapy changes brain function. You know, we talked about how cognitive behavior therapy, hypnosis, EMDR, and that helping people build interpersonal skills changes brain therapy. You need medicine when your thoughts, feelings, or behavior interfere with your ability to function at your potential. And psychotherapy hasn't done it, if you will.